Welcome everybody to the next instalment of the Adelaide Biomed City Research Mini Reviews. And today we've got a focus from the University of Adelaide in particular on obesity. But before going into it further, I guess we begin by acknowledging the Kaurna people, the traditional custodians of the land on which we meet today, and pay our respects to their elders past and present. We also extend that respect to the Aboriginal and Torres Strait Islander people here today. So this is another one of the Adelaide Biomed City Research Mini Reviews, of which we have two presenters today, both of them outstanding researchers and will have a big impact in their respective research fields. And if we start, I'll introduce each in turn before their presentations. So Leonie is going to speak first. So Leonie Heilbronn is the lead for the Obesity and Metabolism Laboratory based within the lifelong theme of SAMRI. And her research focuses on nutritional modulation of insulin resistance. And she's undertaking studies looking at intermittent fasting and altering meals and macronutrition. So certainly I'm particularly interested in what she has to say because like many people, I still need to diet better than I am. So Leonie, will hand over to you in a moment. And just to remind people that we have the Q&A function, that if they can type in any questions there, and then at the question time, we'll address those to Leonie. Thanks, Leonie.
So today I'm going to be talking about circadian alignment of meal timing in human health. So we've known for a really long time, more than 100 years just about, that caloric restriction reduces aging-related pathologies and increases lifespan in rodent models. But really only in the last 5 years or so has it been described how these animals eat. And so when you feed a mouse ad libitum, they eat mostly during the night phase. They are the nocturnal animals, and they occasionally take a pellet during the day, as seen in these red spots in the daylight hours. When you put mice on a caloric restriction diet, they eat almost all of their food intake within a 2-hour period, and they fast for the remainder 24 hours of the day. And this happens whether you feed them at the onset of the dark phase, which is in alignment with their circadian rhythms, or at the onset of the light phase here, which is out of alignment with their circadian rhythms. So I guess the question's really coming up now is it caloric restriction or is it fasting that's having a lot of these health benefits in animal models? So there's been now a lot of interest in intermittent fasting for around about 10 years. So intermittent fasting, I guess, started off as a 24-hour complete fast every other day or 3 days a week. And it really morphed very quickly into a modified fasting diet where people eat around 500 calories during that fasting day. And also the 2 fasting day a week made famous by Michael Mosley and his mini-series. And so that's the 5-2 diet. In terms of research in humans, there's actually only about 14 trials that have been published that are 8 weeks or longer. Most of these trials, and this is in comparison to caloric restriction, most of these trials have, I guess, compared to or powered their trials for body weight outcomes, and really all of them have shown that it's equivalent. So intermittent fasting is equivalent to caloric restriction to reduce body weight. Really, none of them have assessed more complex assessments than fasting metabolism. And most of these trials have also broken that fasting period. And so they've kind of, not really considered when they're allowing the 500 calories to be eaten during the fasting day or what they're giving. So people could eat a high carbohydrate diet in the middle of the day and really negate the effects or negate the benefits of that fast. Insulin will shoot right up, as will glucose. And so they're not really considering, I guess, the circadian alignment of food intake. So we've just completed the direct trial. It's 209 individuals who were randomized either to an intermittent fasting diet where they followed a 30% energy restriction overall, but basically they ate 2 meal replacements at 8 a.m. and 12 p.m. So in the morning, followed by a 20-hour fast. Or they went on a caloric restriction diet, was a 30% restriction in calories every day. We did utilize meal replacement here to match the 2 groups every day, and it was individualized to be a 30% caloric restriction, or they had a weight loss booklet. I don't really have time today to talk about the results from these studies. Rachel Tiong is currently analysing and writing this paper up. It's looking exciting that intermittent fasting is doing really well compared to caloric restriction, but we'll hopefully have more about that data soon. So other things we're interested in asking as we go forward is what really happens on that fasting day. Kai Lu, or Julia, is another PhD student on this project, and she's working with Mark Lawrence at University of Sydney to examine the serum proteome, so we can have a look at a lot of factors that are changing back and forth on a fasting versus caloric restriction diet. We're also collaborating with Tim Sargent, and he's really trying to answer that question at SAMRI as to whether fasting provides a greater stimulus to activate autophagy biomarkers versus caloric restriction. We also have a number of studies going on with Tim where we're looking at low protein diets as a tool to, I guess, dampen autophagy, and how that, one, will it do it, and two, what happens as well with a lower protein diet at around 10% protein and intake. And this is just an acute trials of 8 weeks or so. So I guess why we're really interested in finding out why has our kind of intermittent fasting design perhaps proving superior to caloric restriction when some of the other trials haven't shown that. And I think we really have done that by aligning food provision with our circadian rhythms. So we know that circadian rhythms, they occur in almost every physiological process. This is just a slide pulled off the internet to show you some things that happen over a 24-hour period. Rising blood pressure, the strongest in the afternoon. You've got your highest body temperature in the evening, followed by melatonin secretion and that kind of circular process. But circadian rhythms really allow metabolism to anticipate and respond to those recurrent daily changes that are expected in the environment. And glucose metabolism is no different. If you do a glucose tolerance test in the morning at 7 a.m, you'll have a response similar to this open circle. And so you have an increase in blood glucose, and then comes back down after 180 minutes or so if you don't have diabetes. But if you do that same glucose tolerance test at 7 p.m. in the evening, you have impaired glucose tolerance. And this is partly due to an inability to secrete insulin in the morning in response to that glucose, but also we see differences in even GLUT4 translocation to the cell surface. So the insulin signaling pathway is less activated in response to that glucose challenge in the evening versus the morning. So we also know for around about 10 years now that food intake is a really powerful entraining signal for our body clocks. So the clocks in our head are really entrained by the light-dark cycle, but the clocks in the liver, the adipose tissue, muscle, lots of other tissues really respond to food intake more strongly than they do to anything coming from the brain. So if you start feeding people reverse phase, mice, reverse phase, so they fed them either at night or during the daytime, and you completely invert the rhythms of all of the clock genes, and a lot of the clock downstream genes are changed also. Now in the liver, around about 15% of all genes are cycling, and it's different for different tissues, and the liver is one that's really changes cycling in response to food intake. We also know that if you're a mouse and you're fed a high-fat diet, so you get diet-induced obesity, they start eating throughout the day and throughout the night. So they change that pattern of eating that I showed you before that was really predominantly a nighttime pattern to eat and graze throughout that day. And if you time restrict that mouse and you only allow it to eat during the night, we see this improvement. So you I guess, go back into a high amplitude of circadian rhythms. You reduce adiposity, improve glucose tolerance, reduce inflammation, reduce liver fat. So there's a lot of benefits that we see with these styles of eating patterns. So we conducted a trial where we were having a look at what happens in people. So we put them either on an early time restricted eating pattern, 8 till 5, or we let them skip breakfast and do the same amount of eating from midday to 9 p.m. And we really expected that this early pattern would show greater improvement in glucose tolerance. But what we saw was that both early and early's in black and delayed time restricted eating improved glucose tolerance. And this was in 15 men with obesity, so a pretty small study, and it was only conducted for 1 week. So we thought, okay, let's take a look a little bit longer. We wanted to have a look what happens over a longer time period, so recruited another 15 men. And this time we thought, oh, let's have a look at what's happening over the 24-hour cycle. created this study. These are published also if you would like to read more about them. And so we were having a look at what happens to glucose tolerance when they come over. And we use the facility at McGill. So they have a 4-bedroom, 24-hour facility where we can lock people up and take blood samples over a 24-hour period. So we have these bloods and we have a look at what's happening there. We put smartphone watches and measure their activity and that sort of thing. And so what we saw was that people, when we put them on time restricted eating for 8 weeks, they were eating from about 7 a.m. to around about 10, 11 p.m. every night. We were able to really consolidate their eating patterns down, and we saw reductions in glycated hemoglobin and fasting plasma glucose, and a tendency to reduce 24-hour mean glucose as well by continuous glucose monitors. So ongoing with that, we've now got funding from the MRFF to conduct a multi-site randomized controlled trial. This is run with our collaborators at Australian Catholic University. We're recruiting 268 people with obesity who are at increased risk of diabetes. We either put them onto a time-restricted eating pattern or we give them current dietetic practice guidelines. So they see 5 dietitians, they see a dietitian 5 times over this period, and then we follow them up again at 12 months later. So hopefully we'll finish recruiting for this study by the end of the year. And our last kind of thing we're interested in, this is a publication in Science that just came out, and it's really showing that alignment or circadian misalignment of food intake during caloric restriction reduces longevity benefits. So here they have the normal calorie restriction mouse where they give them that food intake over a 2-hour period. They eat it, they give them all of their food intake at once. They eat it over 2 hours and they fast during the rest of the day. Or they have this CR, they give it to them at the daytime. Or they developed a food pellet delivery system where they allowed the food intake to occur over 12 hours over the entire nighttime period or the entire daytime period, or they spread it out over the entire 24-hour period. So they gave them 1 pellet every 2 hours. And what they showed was that if you do caloric restriction, you do get a longevity benefit, even if you're not fasting, around about a 10% increase in lifespan. You get best bang for buck is when you do that fasting. It's either 2 or 12 hours here, and you align that timing with them. So they get a 35% increase in lifespan. So super excited that we've got this NHMRC Ideas Grant just starting. Got a new PhD student starting in a few months to start work on this, but we're going to try and really lock it down to see whether if we restrict calories or time, what gives us our best bang for buck, or do we need both calories and time to have that improvement in 24-hour glucose and lipid metabolism. So that's where we're going soon, and we're excited to start those studies really soon. So that's my 10 minutes. Hopefully I stuck almost to that. And yeah, it can take some questions if there's time, and just thank you to all of my team because can't do it alone.
Well done, Leonie. You certainly kept to time well. And while we're waiting for questions online, I thought I'd start off. Yet again, they've published how the Mediterranean diet's beneficial in reducing events. Is it what they're eating, or is it the time that they're eating that's important?
So I'm not sure there's ever been some timing looked at with Mediterranean diet. There's only, it's really only in the last few years that people are trying to look at when people are eating in human trials. And I don't know the data as to whether people eat shorter in Italy or not. I think that they often have that big lunch, so they're a bit similar to the French, where they have a big lunch and a bit of a smaller dinner, I believe. And so perhaps we are seeing some of those effects is to moving that food intake earlier in the day. Certainly, if you put it late in the day, it's associated with lots of risks. Shift workers have an incredibly much higher risk of diabetes, obesity, cardiovascular diseases. And we've shown some studies with Siobhan Banks that if you stop them eating, at least in short-term simulated studies, we can prevent impairments in glucose intolerance just from moving that meal timing of shift workers and stopping them eating during the shift.
Okay, so we should all have bigger lunches and have siestas at work, because
maybe we should follow the Mediterranean diet and meal timing at the same time.
Okay. Okay, and the other question I had was in relation to you're comparing with the intermittent diet. Your intermittent diet with the low caloric diet. What about I imagine you've probably got data on A, compliance, and B, what the people involved in the studies thought of either of those options?
Yeah, so we do have data on compliance data. At 6 months, compliance was pretty good with both diets. We had no difference in dropouts. If anything, there were more dropouts in the calorie restriction group than the fasting group. But we found that over time, by the time we got to 18 months, yeah, we kind of gave them a choice as well. So we kind of said at the end of that 6 month period, do you want to keep going fasting 3 days a week? Do you want to move to 2 days a week? A lot of people said, I'm moving to 2 days a week. I'm not going to keep going 3 days a week. Whereas if we gave them the option in the calorie restriction group, do you want to come up to a weight maintenance diet or stay on a calorie restriction diet? They all said, oh, stay on a calorie restriction diet. So I think that, yeah, it's harder. So there is some, I think it is harder to go long-term doing fasting diets, but we don't know how long it is as well. So we did a 4-hour protocol. Maybe we could bring that up longer. Maybe if we did morphed it more 6 hours or longer, we may still see some of the benefits that might be easier to do.
Okay, look, that's very interesting, because if I had to guess, I would have said it would be the other way around, that people would have been...
you know, we need to give them a choice too, I think, because we always do these randomized controlled trials and we don't give them a choice. And yeah, some people do badly on calorie restriction, some people do well on fasting diets. So yeah, we need to take away randomization and let people start choosing what they want to do, perhaps, as well. Personalizing
our care, I guess that's the key thing. Okay, well, look, thank you very much for that presentation, and I think it's a very interesting area, but we best move on to our next speaker. So next we have Associate Professor Tongzhi Wu, who's really an emerging research leader with a steeply rising trajectory in research on nutrition-gut interaction in type 2 diabetes. So Tongzhi had his medical degree in China, but did his PhD at Adelaide University and has continued to progress very well with a number of awards here to facilitate his research work. So he's talking to us today on harnessing the nutrition-gut interaction to optimize glycemic control in diabetes. Thank you, Tongzhi.
Sorry, I was muted. So thank you very much, John, for the introduction, and also for the opportunity to present and introduce our research schemes. So I think to this audience, probably this is unnecessary to talk about the importance of diabetes and glycemic control. Our group has a long-standing interest in studying the gastrointestinal function and how it is, we regarded the gut as really plays a central mechanism to blood glucose response, particularly after the meal. So you will easily appreciate why this should be the case. When you have a meal, nutrients will usually stored in the stomach and then progressively empties from the stomach into the small intestine. And the gastric emptying is regulated to control the delivery of nutrients, to allow the nutrients to be optimize the subsequent digestion and absorption. The digestive products of the nutrients in the small intestine can interact with a number of enteroendocrine cells along the gut, which can stimulate the secretion of numerous of gastrointestinal hormones. So in the context of diabetes, and particularly there is an incretin hormone, namely glucagon-like a peptide 1, so GLP-1. So this is a hormone that can be quite potent to stimulate insulin secretion after the meal in a glucose-dependent manner. It can also act with other hormones to regulate, to slow gastric emptying. So it is quite logical that for us then to study gastric emptying in diabetes, and we're particularly interested in type 2 diabetes. And we also, it's logical for us to understand how and where to modulate the gut hormones, particularly GLP-1, to take advantage the gut capacity to improve glycemic control, particularly after the meal. We have been fortunate in terms of the study of gastric emptying with these facilities within our clinical research facilities. We have the scintigraphy supported by Karen Jones. So we are able to use the gold standard method to measure gastric emptying in patients. So this will allow us to measure both solid and the liquid meal concurrently. We also have the 3D ultrasound technique to measure liquid emptying from the stomach. And more recently, we are increasingly using carbon-13 breath test, so which can be utilized, the C13 can be utilized to label either solid meal or liquid meal, and we can easily collect the breath samples to be analyzed in the central laboratory. And we have been using this technique to conduct a relatively larger sample size or measurement of gastric emptying in a larger population. So what happens for gastric emptying in patients with diabetes? So this is a study measured almost more than 30 years ago by my mentor, Professor Michael Horowitz. So when he measured gastric emptying in long-standing patients with type 1 or type 2 diabetes, and at that time, most of the patients had actually a lot of complications. By comparing the gastric emptying, both solid and liquid, with healthy control participants, you can easily appreciate that a large proportion of patients actually have a markedly delayed gastric emptying. So basically about 30 to 50% of patients will have delayed gastric emptying. But you probably don't see these type of patients more often in nowadays, because with a lot of treatments available, majority of patients in the community currently probably do not have a lot of complications. So we wanted to ask what happens if gastric emptying in uncomplicated type 2 diabetic patients in the community. So as I have introduced earlier, we have been using the breath test as an easy method to quantify gastric emptying in patients with diabetes. We studied over 110 participants, type 2 diabetic patients, and we compared them with non-diabetic healthy young participants and also age BMI matched older participants. So in contrast to what Michael showed 30 years ago, and we were able to find that patient with uncomplicated diabetes, instead of having delayed gastric emptying, compared with those older age-matched participants, quite a large proportion of patients actually display a more rapid gastric emptying. So, and this acceleration, so gastric emptying is accelerated in uncomplicated type 2 diabetic patients, and it does matter. So when you look at the relationship between gastric emptying and the blood glucose response after the standardized test meal, you will easily appreciate there is a positive relationship between the rising blood glucose at 30 minutes, 60 minutes, 90 minutes, and overall, if you look at the blood glucose response within the first 2 hours after the meal, there is a quite nice linear relationship. So I think that this finding really support the concept that for the management optimize the control postprandial glycaemia in patients with type 2 diabetes, we probably will need to deliver a treatment that can slow gastric emptying. So we have tested whether this concept will be effective or not. We have done numerous of nutritional interventions and pharmacological studies. I don't have time to summarize this result, but what we have discovered in general is that if you have a nutritional preload before the meal, which can initiate the small intestinal feedback to slow gastric emptying, it can be quite effective to flatten the blood glucose response to a standardized meal. You can choose a poorly absorbed carbohydrate drink, such as xylose, the compounds. And also you can use the protein, and we have effectively used the whey protein, really small amount before the meal. You can effectively improve subsequent glycemic control. And obviously there are a lot of pharmacological agents, such as GLP-1 receptor agonists. They can be quite effective to do so as well. More recently, we have showed that first-line anti-diabetic treatment, metformin, can also have sustained effect to slow gastric emptying, which we believe that contributes to its glucose-lowering mechanisms. So to move forward, I think that given that patients with diabetes, they often have accelerated gastric emptying nowadays, it is easy, I think it is logical for us to ask whether that individuals with relatively rapid gastric emptying, whether that predisposed them to type 2 diabetes. I guess to do so, we will need to establish a cohort and follow them up for over a period of time, and then to examine whether that would be the case. Alternatively, could the accelerated gastric emptying in type 2 diabetes be secondary to the onset of the disease? And if so, whether this would be reversible with normalization of glycemia? I think the second question would be relatively easy to answer. And we can we are currently conducting a clinical study enrolling newly diagnosed treatment-naive type 2 diabetic patient. Of course, they have inadequate glycemic control, and we can assign them to insulin pump therapy. In this study, we designed a 4-week insulin pump therapy, which will normalize the blood glucose over 4 weeks, and we will repeat measurement of gastric emptying. I'm pleased to share with some interim data with you that we indeed, by looking at the gastric emptying at the baseline, compared with healthy control, gastric emptying is more rapid compared with the healthy control. With the 4-week normalization of glycemia by insulin pump therapy, the gastric emptying has been normalized to the rate comparable to the healthy control. And the magnitude, we further conducted the within subject correlation by showing that the magnitude of delay or reduction or prolongation of gastric emptying is also related to the reduction of blood glucose in those patients. So I think this is quite an interesting discovery. So I also talked about the importance of the gut hormones, particularly the GLP-1 that is secreted from the gut. So about 30 years ago, when GLP-1 was intravenously, there was a work conducted by Professor Michael Nauk. You can see that in patients with diabetes, despite a very high blood glucose to start with, intravenous GLP-1 at the physiological doses can progressively reduce blood glucose. In fact, it's normalized blood glucose over 4 to 6 hours. So this really demonstrates the potential of the gut hormones to improve glycemic control. And not surprisingly, over the last 2 decades, there are lots of injectable peptides that mimicking GLP-1 actions has been utilized clinically to treat diabetes. And there's no doubt these drugs have been highly effective. But what is really interesting is that the real world data, when we look at those, has been reported. The patient who has been prescribed with GLP-1 receptor agonists, if you follow them up over a period of time, that at least by 12 months, I think when you look at them, up to 70% of patients have already discontinued with this use of GLP-1 receptor agonists. We don't know what is exactly the reason. It might be related to its high cost, or it could be the symptom because of the intolerance to the treatment. So we thought that we might be able to the alternative strategy could be by to achieve the GLP-1 related benefits by stimulating endogenous GLP-1 from the gut. So this might be an alternative way to improve glycemic control. So to effectively achieve so, I think we needed to understand where and how the gut peptides is stimulated by specific stimuli. So we have therefore designed a different type of customized intestinal catheters. So in order to targetedly deliver nutrients or therapeutic compounds along the gut to identify the regions of particular interest to target. So you can see that we have these small intestinal perfusion catheters, which can insert it in through the nostril and bypass the stomach into the small intestine. So the catheter that we use can travel about 2 meters below the pylorus. For the areas that we can't reach, we can think creatively by perfusing compounds from the rectum into the large intestine. So I will show you a brief example that of what we have seen in the past. So this is a study that we have perfused glucose into the proximal gut and also perfused into the ileum, the distal small intestine. Small amount of glucose was not quite effective to induce GLP-1 secretion, but if you deliver the same glucose into the ileum, you can induce quite a pronounced response of GLP-1. And using the isoglycemic glucose clamping technique, we were able to quantify the gut-mediated glucose disposal. And here that is quite obvious that glucose delivered to the gut is much more effective. It's about twice as effective compared with glucose delivered to the duodenum in terms of mediating glucose disposal. So the site of, based on this study, I think we needed to target specifically the distal small intestine to improve for stimulation of GLP-1. So we also take a next step to understand what could be the mechanisms, molecular mechanisms that are responsible for nutrient-induced GLP-1 secretion in humans. So we have this nice support from Professor Chris Rayner, who has been my long-standing mentor. He's a gastroenterologist, and with his support, we have the access to human gut tissues. And Richard Yan is a long-standing friend, and who has really helped with the setting up the ex vivo studies to characterize the tissue functions and also the receptor pathways. So with their support, we have excited. I think this is just an example showing that the really recent discovery that we have showed that along the human small intestine, there are quite abundant receptors that can detect the bitter taste, namely bitter taste receptors. So these receptors abundantly co-express with GLP-1. We believe that these receptors will be responsible for detecting the bitter compounds, pharmaceutical compounds, or even the physiological bitter substances that are naturally present in our gut, such as bile acid, which are very bitter. So these stimulation of these receptors could potentially represent a treatment to drive GLP-1 secretion, therefore improve glycemic control. So with their support, we also evaluated the bile acid effects on GLP-1 secretion, and in this ex vivo tissue platform using human ileal samples, we treated the tissue with different doses of or concentrations of physiological bile acids, and you can appreciate, compared with this positive control, bile acid is really potent to stimulate intestinal GLP-1 secretion. So I think this really shifted the concept that bile acid in the gut, they are not detergents to facilitate digestion of fat, but also very potent to drive glucose metabolism. So I think quite excitingly, when you give bile acid, perfuse them into the small intestine, and you can not only see the increase in GLP-1, you can also see quite a profound reduction in blood glucose or the blood glucose response to a glucose challenge. So it's very exciting. We have recently repeated the same experiments in patients with type 2 diabetes, which observed pretty much the same phenomenon. So, but we have to appreciate that along the human gut, there are about more than 40 different types of bile acid species that are floating around. So we wanted to know what could be the best candidate bile acid to use for therapeutic development. And we still don't fully understand whether the mechanism underlying bile acid induced GLP-1 secretion. To effectively address those challenges, we designed, we're currently been collaborating with Professor Heilbronn. He's a physiologist or physicist from School of Physics at the University of Adelaide. We're developing this dynamic tissue platform, namely intestine on a chip, so we can perfuse different treatments into this over this system and treat the culture this human intestinal tissue to determine to address those two challenges. And we're hoping to identify potent bile acids that we can subsequently evaluate in clinical studies. So finally, I wanted to thank all the support from my mentors and collaborators and hardworking PhD students and the research officers, and also the funding support without which we won't be able to do so. Thank you very much.
Thanks very much, Tongzhi. So that's a lot of work that you've certainly done there. We're running short on time, but I thought just one quick question, because certainly what you've shown me today is that the original observation that in diabetics there's delayed gastric emptying, but that's in the complicated ones, whereas the uncomplicated ones have rapid gastric emptying, as you mentioned. So I guess when does the switch occur from one to the other? And could it be, do these diabetic patients develop a neuropathy, and that contributes to it?
I agree. I think that in the older days, that when the gastric emptying were analyzed, I think a majority of participants probably will have diabetic neuropathy. So in the new studies that we have studied, we certainly will screen them whether they have diabetic autonomic dysfunction. And for those participants, I think over 110 participants, we only have 1 or 2 had a very mild diabetic autonomic neuropathy. This might be really the determinant of why the results are very different.
Okay, well, certainly it looks like there's a lot more work to be done in this area, so that will certainly keep you busy for the years to come, and you've certainly been very productive. So that concludes, because we're over time now, but I'd like to thank both of our speakers for tremendous presentations, and great to see tremendous work being conducted within the university and within Adelaide here. And certainly would invite people to view this again, because the presentation is on the website, on the Adelaide Biomed City website, and look forward to people joining us next week for another presentation in the series of the Adelaide Biomed City research mini reviews. Thanks very much, and good night, everyone.